much less common that they're going to come in with traumatic brain injury. And then lastly, where we'll focus today is decreased likelihood of harm after the injury, and that is from the wonderful care that I'm sure you provide here, both on scene as well as when they arrive to the hospital. So I know that this is a referral hospital, so this child could come in, restrained from within this medical center. From what I've heard here, from some of you online, that injury can occur out in the community. And then that can require emergency medical services to take them to an initial retrieval hospital. And this might be outside of Riyadh or somewhere else in the US. This is quite common in many of our cities where they're going to a community emergency department. After that, getting transported to the pediatric referral center where they might need operative intervention or inpatient observation, and then finally to rehabilitation. So this is what we call the continuum of emergency care. And thinking about this child going through this journey, we're going to focus today really on the pediatric emergency department and this concept of time within the pediatric emergency department and how we want to do things both efficiently but also effectively. And if we look at some studies from the surgical journals in the United States, up to 33% of errors, so a third of errors leading to death and trauma, can occur in our emergency department setting. So we really have the opportunity to save many lives by improving our processes of care. So pre-arrival, what happens in your ED? I know in our ED, even as a level 1 pediatric trauma center, there can be a lot of anxiety, a lot of pre-preparation that can be sometimes detrimental. So you want to prepare the people, you want to assemble your team, and from a team perspective, it's very interesting. In a prior talk, I actually used that slide that Dr. Alfifi shared before about changing a car tire while the car was driving. And sometimes this is what this feels like, because you're going into that trauma room. The ED doesn't shut down at that point. You still have patients in your ED. You still have many activities that are going on. You still have your cell phone getting social media updates, but you really want to assemble the team, define your roles, notify your specialists, and then you're going to move on to having those teams function in their roles. So similar to changing that tire, there's a gentleman that was, getting the tire out, another gentleman putting the tire on, so my slides seem to be skipping forward, sorry. But there's going to be someone, hopefully a nurse or a physician, assigned to get the appropriate equipment in the right size, the appropriate medications, and then prepare those systems downstream, making sure radiology, the operating room is prepared. And then little things like warming the room up, which we'll come back to later, that can actually have dramatic impact on care. Getting blood ready, that can have dramatic impact on care. So in the top 5 trauma errors, I would say that looking at the literature, one of the most common errors is teamwork, communication, and preparation. And I'll come back to this in a talk later in the conference, talking about simulation, which is an area of passion and interest to me. So teams that train together, just like that changing the tire on the car, or just like a pit crew in NASCAR, are going to function at a very high level together very efficiently and effectively. So in our emergency department, we have a guide for that. So similar to that pit crew mentality, we have a set of team roles that are assigned. This is a map of our team and sort of how we lay out that team. Then we have specific instructions for each of those roles. And then we actually have stickers that when people walk in the room, they're putting on those stickers to designate what roles they're in. Who is the team leader? Who is the airway provider? Who is the bedside provider? Who's doing the FAST exam? So this role clarity and role designation has been extremely helpful, and it requires ongoing training and preparation, and then feedback or debriefing after. These pre-arrival checklists have really actually been quite helpful, and these are available on a number of apps and a number of other places. And a trauma pre-arrival checklist has demonstrated evidence to improve outcomes because it gets the team on the same page. So you're going to get out that equipment, but use a checklist to ensure that you're not forgetting anything. And I think we're all accustomed to our ABCDE, our trauma primary and secondary survey, but going through that and having a team leader or a team nurse leader that is actually looking at that checklist and saying, hey, we forgot this element of not only the survey, potentially this element of preparation or downstream preparation. So our primary survey, effectively, we'd like to do this in less than 5 minutes. If you've taken ATLS, we talk a lot about not moving on until you have addressed one issue. With our large team sizes in many of our trauma centers, we can do things concurrently. So I would say that we're going to move through here through airway, breathing, circulation, disability, exposure, fast, and then in our pediatric emergency department, we actually put family in there as well, where hopefully by the time in that first 5 minutes, we're getting through our primary survey, moving on to the secondary, we can get some information from the family and provide them an update. And really, to get this done in less than 5 minutes does take very clear roles. It can take actually making sure to do what we call flatten the hierarchy. So if there is a intern that's coming in at our department, they used to start the survey, then the more senior doctor would come in and restart the survey, then the surgeons would come in and restart the survey. And we really worked a lot to train together to improve that efficiency and get it less than 5 minutes and make sure that we're finding any distracting or secondary injuries. So we're going to go through each of those elements. We would look, listen, and feel, and oh, there I am. We would look, listen, and feel, and look at, I'm not sure what's going on, I'm sorry. We would look, listen, and feel. In this child, we might have them strapped to a board and have a collar on. We've made a big effect in the United States by trying to remove those backboards and be more thoughtful about the placement of collars in our pre-hospital setting, because of the fact that particularly in younger children that might impact their airway and their airway positioning. Looking at this child, we see secretions in the mouth, so we're going to use our suction. We're going to Sorry, I lost the ability to advance my slides. Oh, okay, they're back on now. And after repositioning this child, their oxygen came up, we've suctioned them. We're gonna move on to breathing, and with our pediatric assessment triangle, looking at that child, trying to understand, are they in respiratory distress? Are they having compromise? Are they in shock? In this case, the child has some pallor. You see a bruise on their abdominal wall, and they have a respiratory rate that you notice has decreased. So it started out at 30, they were anxious. Sometimes we've given pain medications that might cause this to decrease. Sometimes this might be a continuation of their illness or injury. We are going to then intervene. So we're going to get our chest x-ray, potentially getting our FAST concurrently or after that to look for lung sliding and seeing if there's a pneumothorax. And with our deterioration in mental status and respiratory rate while we're doing breathing, we might move to bag valve mask and, if needed, treating a pneumothorax. So one of the things that often happened in our department was a child like this would go from bag valve mask from an airway management standpoint to intubation. And I think this is another major area for improvement. And we really have stressed this concept of resuscitate before you intubate. So this patient has a very poor reserve because they're critically injured. We'll get back to what that injury is later, but likely going to be some type of hemorrhagic shock. And by putting a tube into that child's throat and giving them medications, there's a likelihood that that child may go into cardiac arrest. So really, I would say that this child does not get a breathing tube for their airway assessment. They get bag valve mask. We continue on supporting the breathing, and intubation will physiologically decrease their systemic venous return, so may actually decrease blood flow to the heart, is going to increase intrathoracic pressure, but actually almost as importantly as the two of those very important physiologic factors is it's going to take time, and it's going to distract the team from that pit crew mentality. So really can lead to decompensation and death. The airway provider can prepare. We want to make sure that they're ready, that that process is started, but continue on with our processes. So airway intubation adverse events, including missed intubations, delays in intubations can also be problematic, but at least in the US, I've found that looking at our research that intubating too early sometimes is highly associated with those missed intubations or delays in other intervention. So as we continue on, we are bagging, now we're moving to circulation. We see that the patient has strong pulses, but 4-second cap refill showing some signs of shock with cool hands and feet. The heart rate is increasing, so now pretty profound tachycardia of a heart rate of 170. And the blood pressure now is 85/70. So we have our circulation providers placing our large bore IVs, sometimes an intraosseous line if they can't get access, giving, and the nurse asks if in terms of your next steps, if you want IV fluids or blood. And in penetrating trauma situations, which unfortunately we do see in the US, not when someone's struck by a bicycle, but for other reasons, this is where we would put tourniquets in, hopefully on scene and not at a later point. I've lost the controls again, sorry about that. So as we're moving on, and hopefully I will get control back of the slides, but with the circulation of this child, you see them continuing to deteriorate. You will likely see a change in their mental status as they deteriorate from a patient that was having good perfusion to their brain and heart, but entering a shock-like state. So their GCS decreases to 9, their pupils are still reactive, so you're thinking less of a neurologic injury, and you notice they're not moving their left leg, and there's an obvious fracture in that leg. So how do you prioritize management in this patient? This fracture might distract you. You might want to get focused on that. But you want to think about initial bolus of fluids, but then really quickly moving to blood, treating the pain, and beginning to get the operating room and other downstream aspects ready if they are going to be needed. So when you log roll this patient and remove all their clothes, you notice this obvious femur fracture, but also the abdominal cavity is increasing in size. Sometimes in our center, after getting the initial fast, we may get a serial fast, and that's where it can really help you to show you that you might see an expanded volume of blood. And unfortunately, this patient's temperature is now down to 35.5 in the room. So you're going to intervene, and one of the key factors in intervening in that child that is often naked and exposed in the room, many of our trauma rooms are warmed up in their temperature, is by recognizing the need to actually warm the child more directly, like we might in the operating room. So placing that child in a bear hugger, putting on the overhead lights, turning the heat up in the room. I would always say in our trauma room, you should be sweating if you're in there. So failure to keep warm, the ACS, American College of Surgeons, recommends keeping the temperature above 27 degrees Celsius. Also, I would recommend using a central thermometer if you can in this patient in shock. So thinking about a central rectal continuous measurement of temperature like we would in the operating room. In terms of your updated vital signs, as you see here, now our A, B, C, D, E are listed there. So we have a cold patient that's in a shock-like state with poor perfusion, a deteriorating mental status, depressed respirations. So they're in a state of shock. There's an inadequate tissue delivery to the tissues. And in pediatrics, I think it is important to remember that this does not require hypotension. Hypotension is usually that cliff where we're getting close to cardiac arrest, so not waiting for a patient to go into hypotension. And in pediatrics, we are not following some of the adult guidelines, at least in our center, of the permissive hypotension at this time. So they're compensated. They have decreased perfusion to the brain and to the skin. And often our blood loss is underestimated, and this is where that serial fast can be helpful to give you an idea if there's active bleeding, potentially from the liver, spleen, or catastrophically from a large vessel like the aorta, and they can rapidly crash. So hypotension, as I mentioned, is going to be a late finding, and being prepared for cardiac arrest when you start to see hypotension, but really escalating the degree of interventions of things like blood products. Thinking about other etiologies of shock is critically important as well. So failure to appropriately treat hemorrhage, and that treatment of hemorrhage can be mitigated by a variety of factors. So one is we want to limit our crystalloid, that in our center we often were giving a 20 cc per kilo bolus followed by another 20 cc per kilo bolus of normal saline. And our surgeons for a long time were saying that we probably need to give blood more often. And then data came back from the battlefields, actually, pediatric data came back from some of the battlefields that really showed some of the adult protocols of one-to-one-to-one infusions of a massive transfusion protocol was very effective in limiting saline. So in our center, we've shifted to this model as we're getting into that second bolus, or even the first bolus if we're giving as a 20 cc aliquot, then moving very rapidly to pack red blood cells. So this patient's losing blood, we need to replace that with blood. Otherwise, we're going to decrease their oxygen carrying capacity and potentially worsen their shock state. So on the right side of the slide here, I have shown what's called the deadly triad. And I think it's very important to understand how the temperature is going to interact with some of the acidosis and coagulopathy. And this is a vicious cycle. So that cold patient that is bleeding out and potentially losing blood factors and becoming coagulopathic will then become to get acidotic, which is then going to precipitate poor thermoregulation, which is thereby going to precipitate poor coagulation function and more hemorrhage. So really in our center, we have moved very quickly to get not only blood, but actually a massive transfusion protocol for that patient. Hopefully we have that PICC crew that can get the patient to the OR when and if they're needed, if they're in shock that cannot be reversed. So we want to order these blood products, get the blood bank to thaw them, get them ready. Some centers have started to move more towards whole blood, which is very interesting and has been demonstrated to be very effective. Some have even started to use whole blood in the field, which can be quite helpful. So in our center, we're giving the packed red blood cells, platelets, moving on to FFP. We're being careful about calcium and potassium. Our center in these severely hemorrhagic shock patients, we are using TXA. The studies are really still out there in the younger children. We're hoping that more information will come. We find the risk benefit towards the benefit and have started to use TXA again in these patients that are going to the operating room, not the mild to moderate injury, but the severe injury and impending death. So for our FAST exam here, we are likely going to see blood. I know that you had a wonderful ultrasound course yesterday, but again, looking not just for a positive or a negative, but looking how that is changing over time. And also looking at the cardiac function, looking at the IVC and SVC to see that how severe the state of shock is. This patient may end up getting a CAT scan. If you were to get a CAT scan, they likely are going to have a high-grade liver and or splenic injury. And one of the key findings going back from some of our pediatric emergency care applied research network studies are really how profound that bruising should be to you. So that's something in that earlier slide of seeing bruising on that abdominal wall should really set you off that this is a patient I should be worried about even before they decompensate. And in the US, our practice is to have the family present. That improves both the child as well as the parents' psychological outcome and actually some of the child's medical outcomes, which is quite impressive to see that having the parent in the room, having the parent there to support them, or at least giving the parent that option. So this patient, after packed red blood cells, platelets, and FFP, their heart rate decreases. They are now sleepy because you've given them morphine or fentanyl, but they're more alert overall. And now they're less alert overall. It's hard to say, is that because of your pain medications or is that because of the shock? And that can be a difficult thing to differentiate. But now it's time to intubate. Now you need to come back to that airway. You've been bagging. You don't want to be bagging for this patient going up to the OR or the ICU, and this patient likely is going to need more pain medication. A very simple and easy thing to do if they don't have facial injury is decompress the stomach, which gives you a much easier opportunity to pre-oxygenate and hyperoxygenate that patient and preparing your equipment. So as you're preparing to intubate, you want to consider some of the injury patterns that we can see. So like in anything, there's pattern recognition. And in this child's hit by a bicycle with this intra-abdominal injury, with that leg injury, if you can have a scene of the crime sort of videotape, which we now see sometimes in social media, likely this patient flew backwards and may also have a head injury. And that patient, unfortunately, in this case, was not wearing a helmet. So traumatic brain injury, again, is the leading cause of mortality. So that abdominal injury can be pretty impressive as you're seeing that fast expanding. The femur fracture can be pretty impressive as you might see something like an open fracture or distracting injury. But the primary brain injury has already happened, and our goal is really to prevent secondary injury. So my approach to this patient would be presuming blood in the brain and doing things that are consistent with the neurocritical care best practices, like limiting stimulation, limiting pain, elevating the head of the bed. So delayed or misdiagnosis, I would say TBI or brain injury can fall into that. Here we might get distracted not only by the femur, but also that abdominal injury. So this is a patient where we really need to be considering herniation, not waiting for herniation. So doing some of those neuroprotective measures. So as that patient progresses in being obtunded, is that from pain or is that from blood in the brain? We don't want to wait until we have pupillary dilatation. We learn all about Cushing's triad. We don't want to wait until that's there. Hopefully we've intervened and done some neuroprotection before that with some of those basic life support maneuvers like elevating the bed and giving pain medication to decrease stimulus to the brain. So if that patient does progress to hypertension and potentially bradycardia and irregular respirations, then we're thinking more of ICP and more aggressive interventions like 3% saline or mannitol to intervene. But really basic things like elevating the head of bed. Another thing that I've learned from our neurocritical care guidelines is opening up that C collar or making sure the C collar is not actually obstructing venous return from the brain. And then osmotic agents and being very cautious about hyperventilation. So we really have made end-tidal capnography our standard. I would say in our trauma review, I don't think I've ever seen someone hypoventilating a pediatric patient. We all tend to ventilate at our heart rate. So most of the time that end-tidal helps us to appropriately ventilate, not hyperventilate. So aiming for an end-tidal of no less than 30, and then considering getting neurosurgery involved again from that systems of care standpoint. Other really important things for neuroprotection, avoiding hypoxemia. So hypoxemia is going to decrease the amount of ATP getting to your brain cells and potentially cause more brain injury. Again, temperature comes in here, so you really want to have a nice thermostat in there. For this, it's unfortunately a little bit more challenging. You can't just go too hot. If the room is too hot, that can also affect brain injury, and avoiding hypotension at all costs. So from a neuroprotective measure, there's some literature going back that had guidelines that supported a really complex process here with things like lidocaine given pre-intubation, and actually arguing that things like ketamine, which we did for many other patients, were contraindicated. Fortunately, the literature really now demonstrates that we can sort of do many of the things we do for other patients. So in RED, we are okay with using ketamine. That ketamine actually, ironically, may have some neuroprotective effects, while before we were thinking that ketamine was actually harmful. We have not used lidocaine. If you are going to give lidocaine or atropine, both of those need time to work. So those would need to be given 3 to 5 minutes before, which usually you don't have 3 to 5 minutes in the situation. Whatever paralysis you'd like to use, if that's rocuronium, if you're in a pediatric institution, if you are in a general institution, that might be a different agent. And then making sure to use a cuff tube. That's really another change in practice in the US, that at any age now we are using cuff tubes. And really not just thinking about the tube, but also it's critically important to think about post-intubation sedation, because that post-intubation time period is a time where that child may be suffering more pain, more anxiety, and having a spike in their ICP. So maximizing our first pass success rate in intubation. I saw the video laryngoscopes that you have yesterday and really was impressed with the intubation training that I heard about from Dr. Alfaifi. But again, one of the barriers to intubation that as a simulation specialist, one of the things that we do is practice very often, but I've recognized that one of the most challenging things is actually getting all the stuff ready. So putting the tube through the cords when someone hands you all the appropriate equipment and resources and positions that child for you is not very challenging. It's more like a video game. On the video laryngoscope, but really making sure to always have a backup plan and have all that equipment ready. So if that's video laryngoscopy, having backup with a direct or potentially anesthesia backup. The tools that our team has started to use from the adult literature that have really helped a lot in pediatrics and the older children are things like a bougie. So actually, this was something that came from some battlefield medicine from some of our military medics, is actually using the bougie as a stylet, so that if you look in, you can't see because there's blood in the airway, using the bougie, not having to take the stylet out and put a bougie in. It's very uncommon that we can't intubate, can't ventilate. I know many of us are often thinking about needle cricothyroidotomy. To me, that's the wrong answer on the multiple choice test of what is your backup plan to intubate. The only time that we're talking about needle cricothyroidotomy is a very different patient than this patient. Something like a dog bite to the face or some type of trauma where we might not be able to anatomically get to the top of that trachea. So absolute last resort. Again, there's sub-checklists for airway. This is one from Boston Children's Hospital. And in their hospital, they actually have a really robust process. And I'm hoping that we can copy this at some point in time. But what they do at Boston Children's, and Dr. Negrovich can comment if this is correct or not, their attendings even have to demonstrate proficiency in airway placement. But they actually have really a guide through the airway procedure. And this is due to some work by Josh Nagler and others, where that guide is reading aloud the items here, knowing that 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 provider has actually been deemed competent in placing endotracheal tubes. And they do this in a really neat way by requiring them to record their passage of the tube and looking at what type of view they have. But having the providers, having the airway, having the patient, and this is another borrowed resource from our colleagues in Children's of Colorado, where actually they make it quite easy. On top of their airway cart, they have sort of this map where you basically need to put each piece of equipment. So instead of finding each piece of equipment and hoping that you have it, they have a little map that you just need to fill in the pieces on the puzzle and make sure that equipment is ready. So after intubation, I would say, we talk a lot about the dope mnemonic, but I really wanted to focus on that pre-intubation and peri-intubation, where I think many more errors happen. Again, this is an acronym that we've all heard many times, and just to reiterate, so thinking if that patient has been intubated and is now decompensating, it could be progression of their disease. It may also be displacement, obstruction, a pneumothorax, or equipment failure. So, we hit these 5 errors here of poor teamwork communication, airway, intubating too early, having challenges with equipment, failure to keep warm, sometimes maybe getting too warm later on for neurotrauma, failure to treat hemorrhage, getting massive transfusion, getting platelets, packed red blood cells, and FFP, and potentially TXA, and thinking about misdiagnosis. So I hope I've hit the epidemiology of pediatric trauma, thinking about blunt trauma being the most common, and abdominal and brain injury being causes of morbidity and mortality, an approach to the critically injured patient, which just to highlight that this critically injured patient, while they had blunt abdominal injury and a grade 4 or 5 liver lac, in our department, the dramatic change, and in the US, the dramatic change is that this patient would likely go to the ICU, and unless they had shock that was not mitigated by blood, would not go to the operating room. So if the patient continued to be in shock, and there's a trial called the EAST trial, if you're interested in looking at EAST, which are some states in the western part of our country, which really demonstrated that non-operative management helps in both short and long-term mortality, because taking out their spleen increases the risk of infection. Opening the abdomen really can actually oftentimes cause that patient that has auto-tamponaded to restart bleeding. And I've hit these 5 common errors. So I guess I'll take any questions at the very end. This is New Haven, Connecticut, Yale. It looks a little bit like Harry Potter to some people. Welcome any of you to come visit at any time. We have a beautiful fall and certainly a beautiful spring that's starting now. Winter's not necessarily the best time, but thank you so much.
Thank you, Marc.